Hi, good afternoon, everybody, and thank you for joining us for today's initial grand rounds of the season. I'm so glad actually to see so many new faces, but so many familiar faces as well. I love this space for so many reasons, including the fact of it sort of being the weekly embodiment of community for our department, both with the folks who are joining us here in the room as well as those online. Just want to say welcome back to all of you who are familiar with this space. And for those of you for whom this is brand new, welcome. So we look forward to seeing you here in class of 62 or alternate locations. Please do monitor the Monday emails to confirm the location or online for our Wednesday round sessions. We are very excited today to welcome our chair, Dr. Lee. Before we welcome him up to the podium, there are a few housekeeping items I just want to mention and remind us of. Number one, we will have a moderated opportunity for Q&A at the end of today's session. So for anybody in the room, you can either raise your hand and have a mic delivered to you. That's a 2025 service, I heard from Sean. That's very exciting. Or if you're online, you can go ahead and use the Q&A function and put those questions in the chat, and I'll read them out loud at the conclusion of the session. The next piece of housekeeping is that with every session, we are going to be sending out an evaluation for you to review the content of the session relative to the objectives and expectations. This is important for a couple of reasons. One, to give feedback to our presenters, but also for you to receive continuing education credit if that's something that's important for you. For those of you who are listening online, we do need you to attend at least 45 minutes of the 60-minute session to qualify for that credit, in addition to completing the evaluation. Last but not least, I would like to say a huge thank you to Dr. Lee and to our administrative leadership team for providing lunch today. As we have communicated previously, this will be an occasional feature for our round sessions, and we also look forward to welcoming you here to bring your own lunch. You can have other people's lunch, whatever you want to do. But just know that if you take someone else's lunch, turnabout's fair play, and the odds are very good you will not have the lunch that you packed the next time. So thank you to Dr. Lee for providing for today, and we're very excited to welcome him up to give the state of the department.
Thank you, Chipora. And wow, this is like my 9th year. I hope everybody can hear me okay, by the way. It's the 9th year of my tenure as the chair of psychiatry, and it's always a great pleasure to update the department about how our department is doing. And I didn't know what usually besides state of department, I tried to do some kind of message, and I kept changing, but I decided we want to talk about making choices. Sometimes you have to make a choice. Should we have a lunch, or should we spend it on something else? And then somewhere along the line is also some of my dilemma, and that I will also talk about. We will talk about the state of the department, and we'll primarily focus on the overall missions of the department, about past accomplishment during the last year, as well as the plan, and also how our department is affected by the recent federal policy changes and some of the issues related to the uncertain times, particularly in relation to cuts to Medicaid and federal grants. And we'll talk about how do we define, how should we define success? And also thinking about how do we define a fulfilling career at an organizational and also the individual level, and importance of identity, values, and data. I hope I don't do too much of a pedantic talk. And I also talked a little bit about what I've been thinking lately, more about moral regrets as well, as a way of preventing ourselves from making those mistakes. Department of Psychiatry, despite all these changes at the federal level, is probably going through the most stable time of my tenure. I have not touched anything about the 7-division structure. Only thing that I tinkered with it is the collaborative care and wellness division is getting larger and larger with 40 plus faculty members. But other than that, overall, the leadership and divisional structure remain exactly identical as last year. Also, our overall, the geographic, space-wise, we remain about the same as well. We'll talk about some of the internal enhancement that we've been making, such as inpatient units and urgent cares and etc. But overall, we remain a 2-campus and 4 ambulatory care center program as it was last year. And overall, as I mentioned, our department is going through a period of stability that we are right now the only clinical department at University of Rochester Medical Center that has a positive margin in relation to both academic side of SMD budget as well as the clinical side of SMH MFG budget. And the data for the academic year 2025 is still not quite available, but as of March 31st of 2025, our academic side of the budget delivered about $1.3 million margin, and the clinical side of the budget also delivered 2.6. Psychiatry department, unlike most people's conception, is not a money-losing negative margin department, and we have proven it repeatedly over the years, and that's why our department is at the financial level very well regarded at University of Rochester Medical Center, and also for what we do academically and clinically, and that's explained by what I'm about to update you as well. Our academic side of development has been, astonishing. We have now, our revenue has gotten to be somewhere around $37 million per year. And there was a time I used to talk about when people ask me, well, what is our department's budget look like? Well, it's a 80-20 kind of arrangement, 80% clinical and about 20% academic. Well, it's the balance has now shifted a bit. It's about 30% academic and 70% clinical. And that number is continues to grow, particularly because our investigators and researchers and those who have been working on service-related grants has been quite successful. And this year we have hit the $27 million mark, and in terms of combined awards this year. And if it was not the federal policy changes, some of the delays and some of strange decisions that's being made at the federal level, we probably would have been even closer to $30 million mark than this year. But that's something we will talk about more. But I just want to thank all the people who are involved in our research missions, service-related mission, overall our academic mission, including education, who has contributed to this amazing success that we've been enjoying. Our success is also reflected by overall our funding, NIH funding ranking, by being able to do approximately $10.5 million. Right now, we are about 30th to 35th. We are bouncing around that number, and we are poised to keep going up. And within University of Rochester, we are right behind neurology, without counting all the, remember, like only 1/3 of our external grants are from NIH. We have a lot of contracts and other federal grants that brings our total to about 27 million. And we are right in front of the surgery department, and we are waiting for the 2025 numbers to see where we are. The robust aspect, the growth of our academic activities is probably the best reflected by how many IRB protocols that we are nowadays managing. And over the last 5 years, we have more than doubled, almost tripled in terms of number of IRB protocols. And also our number of the publication on our ECV among the faculty members have gone up as well. Please make sure you update your ECV as well. Another research highlights that Steve provided. We have done wonderful recruitment of Paolo Lizano, Meredith Ganzner, Corey Crane, and Casey Burberry right before the recruitment restrictions kicked in. So we are in very good shape. Scholarship seminars. Our Q core has also gotten very strong. We now have 5 faculty members supporting variety of statistical and methods related to research and QI related issues. And resident research panel presentation is also another thing that's planned, as we are encouraging more and more trainees to participate in research as well. Education also has been very eventful over the past year for good reason, and for the happy occasions of now we have Jeff Eiler and Amanda Fu will be leading our residency, and Jerry Syke, child and adolescents, consultation liaison, forensic fellowship, and etc. Our fellowship programs are all doing very well. Addiction will have our first fellow this year as well, and other non-GME programs, pre and postdoc psychology programs, master's level family therapy program, CASAC certificate programs, among others, are also doing very well as well. And medical education last year, there was 8 medical students went into psychiatry. And we are also waiting for the reviews related to other HRSA-funded grant. We already added one, but another HRSA-funded grant in relation to paraprofessional training as well. We also welcomed a new group of wonderful PGY1s. I think they're sitting somewhere in the corner right now. And so it's been a great education year. And lots of accomplishment. ACGME site visit for the addiction psychiatry fellowship was successful. And as well as other site visits for the doctoral internship programs for psychology. And then we had to coordinate extra number of the medical students, but that was done very successfully thanks to Laura Cardella, as well as other medical education administrators. And under Tsipora's leadership, this is year 2 of a shared didactic day on Wednesdays, as well as we have established now that we have a lot of informal volunteers and shadowing and visiting trainees, and that's also getting well organized. And also we have launched and we have conducted faculty development sessions, and faculty education orientation is also another thing that's being planned as well. Overall, this is one slide that I was very amazed that we have a total of 218 trainees in our department over the course of the year. We are the largest pipeline, a personnel pipeline for behavioral health services outside of New York State, New York City, that is. And we are continuing to do wonderful work through our education mission. On the clinical service, of course, there are lots of things that's going on. I mean, in our CPAP inpatient mobile crisis team and crisis call lines and partial hospitals, in acute services have been very busy, and I'll give you some details about as well. And ambulatory care services, it does need a little bit more analysis. I spent last night looking at the data a little bit more, but we do need to look at it a little bit more in detail. the biggest news probably is the Brighter Day Pediatric Mental Health Urgent Care Center that we opened last year. And it has already seen more than 4,000 visits, more than 4,000 visits in the first year alone. And that has led to decrease in CPAP volume particularly for the pediatric. Overall volume has gone down by approximately 5%. But the primary decrease is on the pediatric side, as we expected, about 25%. We are tracking, particularly during the first 6 months of this year, there's about 25% decrease. We are publicizing more. We are also looking to do more in our urgent care center. And I expect that number will continue to have impact in the CPAP, particularly in the pediatric side. The irony, however, is that the adult side has not budged at all. And that's something that we're going to have to keep watching, because with these changes in Medicaid and federal funding related issues, are we going to see more uninsured, more homeless populations with mental illness who might be utilizing our acute services even more? Is something that we might have to think about. A variety of those issues are on the air as well. Child Psychiatry Division has been doing wonderfully in relation to continuing to see a lot of ambulatory care services, and also expanding the school-based programs as well, in terms of providing training and consultations, and it keeps adding more and more schools as well. And then it is also starting to collaborate in Monroe County to support creative arts therapy program, and soon to be, and also there's the size of our faculty in child psychiatry also keeps growing. It now counts 47 faculty and 11 PAR faculty members who are actively engaged in providing this really large group, or a large number of the both inpatient and ambulatory care for the children in our region. And we also welcome the new academic chief in area, Sheftel, along with these new faculty members as well. And the goals, besides that they'll be staging this play like last year, called Good Man, Charlie Brown. You're a Good Man, Charlie Brown this fall. But it continues to collaborate with the Hillside to begin next step programs. Because one of the issues that we are now encountering are these kids who are stuck in our CPAP and sometimes abandoned. And we do need to do something about it, particularly those with IDD and developmental disorders. And also, we now that we have a new 490-200 adult unit that really increases our urgency in relation to developing a better inpatient space for our child and adolescent patients. And that's something that Michael Sharp and Patrick Setch and many of us are involved in trying to push for better space for the children as well. And of course, that as the child psychiatry division is growing, it's beginning to run out of the space as well. And also it is looking to add school-based satellite clinic for the Rochester City district as well. I don't know if everybody had the chance to watch the 490-200 inpatient unit. It was a $10 million project, and it's a beautiful. And I think that the actual video of the opening ceremonies and etc. ribbon cutting is still up in our website. But we are not quite done yet. We are actually approved for another $3.6 million renovation for 39000. And eventually that's the location in which the child psychiatry unit will temporarily move in, with the hope that eventually it'll have even better space. And it will increase the overall adults bed by doing this from 56 to 63 beds. We are thinking that will reduce the number of the boarded patient in CPAP and reduce the overall volume as well. And we are also looking to develop psychiatric ICU to manage the severe agitation in a more safe and monitored environment, and also develop more specialized path to really deliver better psychotherapeutic care for those with early psychosis and hopefully at some point mood disorder as well. Our acute and adult service continue to recruit faculty for clinical services, and several of them are listed. I'm particularly very happy to see how our psychology program for our inpatient unit has been developing more and more organized and expanding its scope as well. And the 49200 expansion of the adult inpatient services will provide lots of new opportunities for training and education. And hopefully that will also lead to better and more supervision for the residents as well. And other future goals that were listed by Sue Giovanni, our vice chair of the clinical services, besides recruitment, we are really looking to transition to more of a specialized units, more focused on psychosis, more focused on mood disorder once 49000 is converted into adult inpatient unit. As I mentioned, we are looking to develop psychiatric ICU as well, and variety of others, and also continue to do our best in terms of integrating clinical research into our clinical care programs as well. The ambulatory care program is the one that I kept looking at the numbers to see, are we headed to the right direction? This is the first year that we are actually seeing signs of plateauing number of our overall volume, or even perhaps somewhat decreasing. And we're going to need to do a little bit more deep dive into these numbers. But overall, what we have always counted in terms of 2 to 5% increase in terms of our overall ambulatory care volume, if you really count everything, maybe there is a slight increase, but overall, there is some signs of slowing down in relation to our ambulatory care volume. And that's something that we're going to have to do our best to manage and really think about what it means. And this is the overall outpatient completed appointments that is prepared by Kristen McDonald, one of our lead administrators, that see that little curvature that we have. That actually represents for the first time the ambulatory care volume slightly going down. Now, I don't know if this is a correct number, or do we add the urgent care numbers on top of that, or we will figure that out. But I do feel like our number for the ambulatory care is actually probably it is about the same or even decreasing. And that's something that we also broke it down by the overall division as well. And some divisions are continuing to increase, particularly collaborative care and wellness, as it has also added that faculty practice also and expanded its footprints in other departments in terms of embedded and collaborative care programs. But other programs, geriatric is also somewhat increasing as well, as it's now doing ADC models, and eventually also the guide model to increase its numbers and keep adding those numbers. But other divisions are more or less plateauing in terms of completed number of the visits. And we'll be looking at that to see what does that mean. Having said that, our department, as of 2025 today, is where we wanted to be when we talked about becoming a department with permeable boundaries, wanting to embed behavioral health in any settings and all settings. And you can see in the adult side, there are lots of embedded programs almost everywhere, starting from anesthesiology to dermatology, family medicine, internal medicine, sleep center, neurology, surgery, cancer center, and many of the transplant programs, as well as pain programs, all those things as well. And also for the pediatric side, child and adolescent side, it's very impressive in terms of how our child's program has also managed to put behavioral health in many different settings, ranging all the way from GI to neurology to sleep to allergy. I'm not going to just read all of them, but we have now become very important contributor to overall enterprise of the URMC Medical Center in all its care delivery system. And the Department of Psychiatry truly is no longer an isolated department. And in fact, we are now also providing essential service in education as well. And the coaching program that's run by Lauren DiCaprio Ryan and also Susan McDaniel is also providing coaches for 13 different residents. And they are embedded to support all of these GME residency programs. And in many ways, the Department of Psychiatry has become very essential aspect, essential partner to every one of the departments in our medical center. Overall, we are right now busy analyzing our ambulatory care data, but overall we want to, according to George Najo, prepare this slide. We want to centralize access so that we can create a single coordinated front door to the all ambulatory psychiatry services. It's going to be a tough task, by the way, because we have such a heterogeneous, such a decentralized system. But this is something that we need to be committed to provide. And also, we're going to continue to increase our capacity and access, and also build a true continuum of the care. We don't want our patients to fall through the crack, and we'll do our best to fill those gaps. And also, this is the year we are really committed to create a robust interventional psychiatry program that will utilize the most cutting edge mood disorder treatment available. With all these things going on, we probably will have to do something about our wellness as well. And I asked Autumn to pull our data related to wellness data. Over the past 3 years, from 2020 to 23, it's been relatively stable. It's been relatively stable in terms of majority of the people feeling that they are satisfied with their current jobs, both staff and faculty members. And overall, the burnout number is approximately about 35%, which is not a great number, but it's still better than the national average. But with all these activities that's going on, we do have to wonder, what would it look like if we survey again in 2025? And that's something that Autumn Gallego, our wellness officer, will talk about in relation to thinking about the overall wellness of our staff and faculty and trainees. So to summarize the overall Department of Psychiatry, we continue to be quote unquote successful by anybody's measure. We're doing financially well. We're providing big volumes. We are writing papers. We are getting grants. We are educating, training lots of trainees. And we are continuing to grow in all phases. Ambulatory care side, we do need to take a look to see if we are missing something. And overall, our inpatient program particularly will grow as we add more beds. And we will continue to work on our overall physical structure inpatient-wise and look for ways to improve our space related to ambulatory care as well. And the fourth quarter data, which is not quite available yet, third quarter looked very positive, but it'll really tell us as to where we are in terms of financially, in terms of our overall clinical data. But that goes to this idea about how do you define success in our department? So this is something that I've been hounding our associate chairs, everybody, Sue, Steve, Chipora, even Telva and others too, and Michael, and asking them, what does success mean to you? How do you know that you are more successful than the year before? Where are you headed? Where are we headed? And that's something that brings back to why we need to be asking this question even more urgently now, is because we are likely to go into more and more financial uncertainty. As you know, that in last July 4th, President Trump signed the one big beautiful bill that led to about $1 trillion in a projected cut in terms of Medicaid funding. It also cut a lot of different things like food stamps that many of our patients rely on. And it's a concern that is particularly relevant for Department of Psychiatry. Just to give you an idea of what we are looking at, this will make about $11.8 million people uninsured. That includes about 1.5 million people in the New York State. And the cost of unreimbursed care that's expected is probably will be shifting to the hospital. We do wonder if the New York State will step in to soften this blow, but we don't really know. Also important is the federal grant funding cuts. Now, it's still a bit unclear how much of a cut we are looking at for NIH, SAMHSA, HRSA, NSF, and etc. Overall, university receives about $500 million in federal grants, and with NIH being the biggest source, about 300 million. Now, as people have heard about how the current administration is proposing to cut the federal indirect cost from to about 15%. So 53% is our current rate at University of Rochester. If it's reduced down to 15%, it'll be about 70 million. What does that mean in terms of losing about $70 million for the University of Rochester School of Medicine? Well, it'll probably mean approximately 2 to 2.5 million annually for our department. It's a sizable impact to our department's budget, but probably something we can still withstand. After all, our department's budget nowadays annually is about $180 to $190 million a year. But as we are putting these austerity measures that we've been talking about, and as well as some of the restriction that's now being imposed in terms of faculty recruitment, it will matter to us. And the other thing is, as the federal agencies are potentially reducing their budget, we do wonder if it'll get harder to obtain federal grants through NIH, SAMHSA, and HRSA than before. Although our investigators has been remarkably successful in terms of obtaining these increasingly competitive environment, with a lot of assistance from our research administration led by Natalie. But what's probably even more worrisome is the Medicaid cut. So basically right now, the federal government funds approximately 70% of the Medicaid costs in New York State. And right now we are projecting about $8 billion in terms of reduction in funding for the Medicaid. And we don't exactly know what will be the local impact. But to give you an idea as to why I would lose sleep over this without even knowing what would be the impact of this for us. Well, about 50% of our overall clinical revenue is from the Medicaid. In fact, more than 80% of our inpatient revenue is from Medicaid, Medicare, and about 2/3 of our outpatient revenue is also from Medicaid and Medicare. In other words, that any hits to the overall federal funding in relation to Medicare and Medicaid, particularly Medicaid, is something that we really wonder and worry about. One, I don't know if it's a good news, but at least most of the cuts to the Medicaid, now we know the overall timeline of how it's going to be implemented will be after the midterm election. So it'll happen probably starting early 2027. So we have about a little bit more than a year and about 3 months, I guess, to prepare for how we can adjust to the new reality of what might happen. And that relates to the topic, the subtitle of my talk. What is our path in relation to our choice? And our choice, because it will reflect our values. Overall, because of all the hard work that everybody has done in all phases of our mission, our department, as I mentioned, is probably at the most stable financial as well as structural shape that we've been in the last several years at least. And regardless of what the impact of the federal funding cut would be, we should be able to withstand it without compromising any of our missions. But the overall, we do have to keep in mind, resource reduction means resource allocation decisions. And we have to be prepared to ourselves to make difficult choices in the future. And that goes back to how should we make choices? In terms of really thinking about what is our identity as a Department of Psychiatry, University of Rochester Medical Center, what are our values? What do we really care about? And the choices. Now, this choice, we first need to know what is the situation at hand, and do we have the right type of the data and information? And do we make the decisions with the right timing? And do we have enough data to be able to evaluate an alternative? And that's the exercise that I'm trying to go through with my associate chairs and division chiefs soon to be, and our administrators, to really become increasingly more data oriented so that we can evaluate more timely basis and more real time so that we can make more decisions in a more timely way. The choices are important. We also make choices in our career, in our life as well. And I put a couple of the quotes that I like. Life is a matter of choices, and every choice you make makes you, or our choice makes our destiny. In other words, we go through lots of different choices in our daily decisions. And as I think about my own decisions as chair over the past 8 years, and I also think about my own the decisions in my life as well. And recently, I got into this interesting conversation with one of our leaders as to, what do I think about when I get a job, or what do I think about? I think about regrets. I think about choices that I have made over the years, and in fact, I'm one of those. I guess I think about what would I like to say when I retire, or what would I like to say to my colleagues when it's my last day of the job. Not that it's anytime soon, but those are the kind of things that I think about. Uh, um, and one of the poem that I like is a well-known poem that I'm sure everybody's familiar. The road not taken, the two roads diverged in a road, and I took the one less traveled by, and that has made all the differences. And we have to think about when we have to. Do we make the choice to make choose the road that is less traveled by? And our choices that our department should make should reflect our identity. We are, regardless of what you think, and regardless of how we think about, we are an academic clinical department that wants to do our best to not only preserve the academic missions, education, research, clinical services, and we want to provide high quality, compassionate care in our community, powered by our world-class researchers and teachers and clinicians, and do our best while keeping our vision of Department of Permeable Boundary across the missions, also very important across the disciplines and the care setting. We come from different walks of life. We might be psychiatrists, psychologists, therapists, family therapists, nurses, APRNs, and etc. But we are providing a team-based humanistic care driven by cutting-edge science and education excellence. And that's who we are. And that's with that as the vision and mission, and with our value of being able to take the spirit of biopsychosocial model that provides that we talked about: collaboration, communication, complementarity, competence, and compassion, as George Engel talked about, are the foundation values that we work together to advocate and support our vulnerable patients through our clinical care, education, and research. And those are the values by which that we will try our best to make choices as difficult decisions come across. We talk about our Department of Psychiatry is community of like-minded people, and we are Department of Advocacy for the vulnerable people. And my personal goal as a chair is that with those missions, vision, and values, how do I ensure that every faculty, staff, and the residents and trainees find a fulfilling career in our department? And that goes back to my question. What does your success, what does your fulfillment look like? It's something actually that I ask usually when I interview someone for faculty or staff position. And sometimes I also ask the trainees as well, what do you like? What do you want to have as your goal in terms of wanting to have a successful career? Now, one of the regrets that I have is that we haven't quite developed the data structure in our department. Now, I actually pulled this slide from 2022. At that time, we were already thinking our overall growth that was becoming incredibly rapid and expanding. We have pretty much tripled our overall size of our ambulatory care, as well as overall faculty size and also research program. We thought that we'll be angling for the overall smart growth through informatics. We implemented Epic behavioral health module. We also aim to develop health informatics teams. And we also wanted to develop department data structure that connects research, clinical, and education missions. For each of these areas, we have made some headways, and that is our 5-year goal to develop our psychiatry department learning health system. But we are still pretty far. We are still pretty far. Some of them we have been making good. Research Q-Core is one thing that we are very proud that we are able to develop. Some of the clinical data reporting, that's still a work in the air. Clinical informatics side, Kayla has been incredible in terms of overseeing that, but some of the people obviously listed here is no longer Michael Hasselberg, and Conrad Gleber is no longer at the medical center. So there's still a lot of work that should be done. And because there is an importance of data and dashboard that when we are thinking about making, we need to make choices. At a departmental level, obviously, I have to be able to have a dashboard to be able to share. At the mission level, each of our associate and vice chair needs to be able to make decisions. Clinical division level, service level, also at the divisional level, I would very much encourage everybody to be thinking about data in terms of the performance, productivity, and where you want to go, how you want to define your success. And then one thing that I do want to think about as you are facing with these things related to the choices that we make. I think I mentioned that this is something that I think about. I guess it reflects my own personality. I think about what I'm going to regret when I retire at 70. And that's my goal, is to retire at 70. And there is a popular writer named Daniel Fink who talks about 4 types of regrets. One is a foundation regret, something like, if only I'd done the work, That's one regret that I don't really have. I think I generally work hard. Boldness regrets. If I'd taken the chance. Connection regret. If I'd reached out. I don't have problem with those 3 regrets. You make them, you learn from them. The last one, however, I do wonder about moral regret. If only I'd done the right thing. It's particularly relevant to those who are in the business of advocating for our vulnerable population. Because even in my career, I think the moral regrets, only if I had done the right things. I think about some of the regrets that I have about my clinical care, that I made the wrong decisions, or research, or even when I'm teaching or mentoring someone. I wish I had done the right thing. And overall, my lifetime goal is to avoid as many of them as possible. Because that way I can learn from my decisions, and by reflecting it, and I can get a deeper insight into my values and be able to avoid the future problems. And then along with that is the importance of a cultural humility that I become increasingly more interested. It's an important value that we should adopt as a department, really thinking about self-reflection and self-critique that acknowledge our own biases, and really think about how we are limited, and being able to always seek to learn, because we are able to know how limited we are. And there's a verse that I like: if I must boast, I I will boast of the things that I show my weakness, the St. Paul once said. And the regrets combined with cultural humility that leads to better choice in the future. And as we are faced with tough choices, not immediately, perhaps a year or more from now, when we are faced with more financial decisions that we might have to make, those are the things that we have to drive based on. So overall, I wanted to let you know, in summary, the state of department has been marked with continued expansions of pretty much everything except ambulatory care. We are still looking to see where we are. And we are headed toward financial uncertainty, not immediately, but in about a year or so. And we will have to evaluate, continue to reaffirm our identity as academic clinical department and continue to stress our values and also become more data-driven and as we make value-based choices. So as we do that, I do hope that we can avoid moral regrets and avoid repeating the past mistakes from the past. And we should strive to make data-driven, value-based choices to shape our future together. So, thank you.
Thank you so much, Dr. Lee. We do have a few minutes for questions. We have one that's come in online, but figured I would start with folks in the room. You can have your own microphone. That way? Yes. This way? This way.
Thanks, Dr. Lee, for that overview. I'm curious, as you noted, there's a lot of uncertainty when it comes to the financial implications of the quote unquote big beautiful bill for our department and the institution, but it seems like it is certain that there will be a lot of implications for our community, whether we talk about like cuts in SNAP benefits or cuts to health insurance and rationing of healthcare, which will have direct impacts on the emotional health of our community. So I'm wondering, as we think about that as a department, what creative ideas you have about how we'll respond to that increased need. Thanks.
Yeah, I think it's a very important question. I think we have to engage the community more actively. And I think that's why we are also thinking about, as you know, recently our Office of DICE have shifted in terms of its focus to be more focusing on the community outreach and becoming more embedded in our overall community. We're going to go through strategic planning in relation to that particular goal. Now, some of it is, of course, also forced as well, right? I mean, it's something that every department, every institute have gone in relation to the diversity and inclusion agenda in terms of how we should. Now, we've been very active in terms of expanding our DEI agenda over the years. But this is the year. But we should look at it as an opportunity rather than a stepping back from that agenda to be able to do more engaged with the community, providing more access to the community, and be able to more work closer. So that's one of the things that we are looking to do.
Thank you, Dr. Lee. We have a couple of questions online. One is, what's the department doing in terms of the field of telehealth? And how does that fit into the strategy?
I think, you know, one of the things that we have started to do and expanded to do is linking the crisis call lines with the telepsychiatry evaluation so that those patients who are in crisis will have telepsychiatry access, and we do hope that that will continue to expand. All of our clinical services, ambulatory care side, have a telepsychiatry capability. Having said that, it's an interesting time because the area of telepsychiatry is now saturated with lots of commercial entities such as like Better Health and Amazon's and etc. The mild to moderate level of the care, we're going to have to watch how the market is. And I do expect that telepsychiatry over our times, actually over the past 3-4 years in our department, if you look at the overall volume, it has gradually decreased. It's something that we're going to have to strategize and really rethink in terms of how we are doing.
Thank you. One last comment just to share. I appreciate your reminder of how taking the road less traveled can make all the difference. I think a huge part of having a successful career involves being part of a professional community that takes action in local, state, and national arenas in support of meaningful values. This helps the respondent reduce moral regret, and I think that's probably true for most of us. Do you have any other ideas about how the department plans to enact those aspects of advocacy and care for vulnerable people in a broader context, including potential pressure on the institution, local and national policy?
Yeah, I think, one of the things that we should think about is really becoming actually, despite the funding cuts that we are facing, we have to find a way to disseminate our overall biopsychosocial spirit and philosophy, as well as our sense of advocacy outside of our region and institute. There are a lot of things that our department does well that should be better disseminated. A lot of things that our child psychiatry division does is quite incredible. Our MIPS unit, what they are doing, some of the collaborative care, early psychosis programs, and etc. We need to do a better job of disseminating them out to the field and be able to do that. Now, in terms of moral regrets, we need to get more active in terms of participating in local community as well as the national community, and be able to advocate more for the mental health and more for our patients. And this will become increasingly more important as the time passes, as we are looking to see, all these things that are related to the Medicaid insurance coverage loss. I think our patients are particularly more vulnerable than others. And we have to find a way to effectively organize ourselves to advocate more and lobby more sometimes.
Well, on behalf of those of us here in the room, as well as online and the entirety of our department, we'd just like to say thank you to Dr. Lee for the summary of our accomplishments and some future visioning that's guided by values. So thank you so much. And have a great afternoon, everybody.